Hello. Thank you everybody for joining. I hope that over these next couple of minutes, I'll be able to give you a little bit about the history of lung cancer screening, give you some reasons why you should consider getting screened, give you information that you can tell your friends or family members if they fit the criteria for screening, and then also just have more information in general about screening and fit in with these other topics here so that you can live healthier lives. So with that, we'll go ahead and start. So lung cancer, as many of you may not know, is actually the #1 cancer killer. And so many people die from this yearly. And one of the problems with it is that it's often diagnosed late stage, meaning either stage 3 or stage 4, because it usually doesn't have any symptoms until that time. So there's been many different efforts over the years to try to figure out what's the best screening mechanism. And in 2011, there was a huge trial. It's called the National Lung Screening Trial, which included over 50,000 patients. And they looked at whether or not there was a benefit to screening individuals that had a smoking history with either a chest X-ray or a low-dose chest CT. And basically, that chest CT, it's a study that takes about 1 minute to finish. The whole process takes about 15 to 20 minutes because you need to come in and check in. But they put you onto a table, and then that table puts you into a donut that will screen you. And it screens just your chest area, basically from the top of your lungs all the way down to the bottom of your lungs. And it looks to see if there's any abnormalities, such as nodules or tumors or anything else that's abnormal in your lungs there. They did this study on this number of patients and reported a 20% lung-specific mortality reduction, meaning that 20% of the individuals were saved solely because there was a lung cancer diagnosis or lung type of disease process identified that ended up saving their lives. In general, 6.7% had an overall mortality reduction, meaning that they found something on this study, whether it was with their heart, somewhere else in your chest, somewhere in your lower neck, that actually saved their lives. And so I should point out that with lung cancer screening, it is the only screening mechanism that has both a lung-specific mortality reduction, but also an overall mortality reduction. And so again, this wasn't a study of individuals that had a history of smoking. So as a result of these findings, many organizations published guidelines recommending annual screening for high-risk patients in 2013. And Alice just asked a question, and it's very important. I'll get into that into the next slide, but yes, it is fully covered by your insurance. We'll get a little bit more into the specifics a little bit later on, but yes, it's considered preventative care. So just like when you go to the dentist and you get a cleaning and it's covered, the low-dose CT is covered, okay? So the initial guidelines were here, okay? And again, this was back in 2011, and it was individuals 55 through 77 years old, those that were still currently smokers or had quit within the last 15 years. And the tricky part is the pack year history, but once we break it down, hopefully it's not as tricky. But it's those with what they consider a 30 pack year history. So what that means is smoking a pack per day or the equivalent for 30 years. So it could be 1 pack per day for 30 years. It could be 2 packs per day for 15 years. It could be half a pack per day for 60 years. Any of those combinations to get you to that 30 pack year history were what those original guidelines were. There was a couple of other criteria, given that we're dealing with patients that would be more mature. Your life expectancy was expected to be more than 3 years. You can't have any other type of cancer because you're going through surveillance with that, and that may affect the results on this. You need to be willing to undergo treatment if we do find something on the CT, and I'll talk about that in a little bit. And then you also just need to have no other major comorbidities, meaning other health problems that would prevent treatment. So if you weren't able to undergo treatment, then we don't recommend undergoing screening. Next slide. And so much like breast cancer screening with mammographies, they came up with a scoring mechanism. And I won't go into the details of this, But a lot of this came about because they needed to come up with a standardized way to read these chest CTs and make it standard across the board of what does it mean when we see a 5 mm lung nodule versus a 2 cm lung nodule versus a 10 cm lung nodule? Or what does it mean with the different types of nodules? Or what if we see another abnormality? And so they came up with something called Lung-RADS, and much like most people will know about BI-RADS for mammography, there's Lung-RADS for lung cancer screening. And again, the purpose of this was to kind of level the playing field across the board and give our radiologists a standardized method to read each CT scan and then come up with a scoring system for it so that providers across the nation would know what to do with these results. The first two, I'll go over them very quickly. The first two just mean that either you had no findings or we found findings, but they're benign in nature. If you're a Lung-RADS 3, that means that we found something and that we should probably get another CT scan in about 3 months, just to make sure, 3 to 6 months, just to make sure that everything looks okay, or that this is either going away or it's not getting any bigger. And then Lung-RADS 4, there's 3 different categories, 4A, 4B, and 4X, which basically categorizes that, hey, this is pretty suspicious. We either think you need to come back in 3 months or you need a referral to a thoracic surgeon, etc., in order to get this worked up a bit. So again, this was here to standardize the screening process. Next slide. Unfortunately, when this first came out back in 2011, between 2011 and 2014, there was some misrepresentation of the false positive rates. And it actually made it to the New England Journal, which is one of the most prestigious journals that you can publish in. And the false positive rate was actually listed at 97.5%. So naturally, providers were, said, pump the brakes, we need to hold on this. And unfortunately, a lot of people missed out on that screening because that false positive number was reported incorrectly. It was a VA study that this happened in, and the true false positive rate at that time, as you can see in the chart here, was actually only 27%. Since that time, it's gotten much better. And so when we looked at the database back in 2018, we were down to 15%. And then here at Dartmouth-Hitchcock, we've been at about 5% for the last 5 years almost. So that means that out of 100 people that get screened, only 5 may have a false positive rate. But of those 100 people, lives will be saved, not only from lung cancer, but from finding other diseases. Okay, so go ahead and next slide. So now, fast forward, this initially came out about 10 years ago to the date. It's 2021, and this came out in 2011. We've gotten much more data on many different populations. We know that those guidelines that they initially created were great, but it also leaves out some folks that are at high risk for lung cancer and that we're just missing with the screening criteria. So the United States Preventive Services Task Force just recently came out with current guidelines, and that includes 50 to 80 years old. Okay, so they've dropped it now from 55 to 50. It's still those that currently smoke or have quit within the last 15 years, but it's now those that have a 20-pack-year smoking history instead of 30-pack-year smoking history. They realize that in certain populations, specifically Black and African American populations, those that of lower socioeconomic status, those that have less access to care, patients were starting to smoke at earlier ages. They weren't quite reaching the 30-pack years, but because of their history of smoking earlier, they were getting lung cancer earlier. So they have these new guidelines. Now, to go back to Alice's question, currently, Medicare and private insurance companies pay for the screening if you meet that original criteria. Medicare is up to review these guidelines and should be going over those by the end of the year, but they are not yet covered by all insurance companies. So it's important for you to ask your insurance company, hey, do you cover this screen for me? Because otherwise you would need to pay out of pocket for it until you reach that age of 55, but most likely these will be approved by insurance companies within the next year to two, okay? So where we are today, it's unfortunate because this is such a great screening tool, but it's a large number of patients still don't participate. It's estimated that only about 5% of eligible patients participate compared to about 70% with breast and colorectal screening. There's a lot of reasons for that. I think the number one reason is people don't know that it exists. I see so many patients that come to my clinic and don't know about it and don't know to ask for it. Whereas things like colonoscopies and mammograms are pretty commonplace in our society, and most people either know about them and maybe even dread them, but they go and do them. Unfortunately, we don't have that same benefit with lung cancer screening. There's a lot of patient roadblocks in terms of access, as I was talking about before. There's provider roadblocks because there is a shared decision-making conversation that needs to take place before an order can be placed for you to have this. And it is very hard, as you can imagine, when you go to see your PCP and they're talking to you about all of these different screenings, to talk to you about other things, specifically lung cancer screening. Here at Dartmouth-Hitchcock, we've tried to assist our primary care providers by creating the Pulmonary Nodule Clinic, which can have the shared decision-making conversations with you and talk to you about specifically the risks, the benefits, okay, and why you should consider participating in lung cancer screening. So we're hoping to overcome some of these barriers. But we really are trying to do our best to get more engagement from the population. So I think I have one more slide. So what can you do and how can you help yourselves and your community? Well, I think number one, learn more about lung cancer screening. Hopefully you got some questions answered about what it is and who qualifies for it and how it's paid for. The one thing I will say about paying for it is that, say for example, they find something on your lung cancer screening CT, if you were, or you fit in that LUNGRADS 3 category where they recommend another screen, that's when your insurance would start to kick in and it would start to pay for these things, and you would start to see the normal deductibles and copays that you would usually do, just like with a mammogram or a colonoscopy, if they found something on that too as well. So that's important to remember, but again, the benefit that you would gain from it and possibly diagnosing lung cancer at an early stage, we really feel is worth it. And so it's definitely something to consider. Two, I would ask you to ask your primary care provider if you have more questions about it. Be an advocate for yourselves, and it's okay to ask about this, or ask your friends or family if you have anybody that you know in the medical field to help give you more information. You can also go to the United States Preventative Services Task Force website to see the guidelines and see more criteria about it. Encourage your friends and family members to speak to their providers. If you know anyone that has a smoking history, whether they're a current smoker or if they have quit within the last 15 years, they may qualify. So tell them to ask their providers about this. And then the last thing is that if you do still currently smoke, it's never too late to quit. We have a great smoking cessation resource center here that is here to help you with your needs and help you to try to stop this habit, but more importantly, get screened and look out for things that may have affected your health or may be affecting your health. It's important to note that not everybody that has lung cancer smokes, okay? About 20% of the population doesn't, but we know that 80% do have a risk factor of that. And so if you do, I encourage you to go and get screened. And it's a yearly process, but it's a process that could save your life. So I thank you for your time and attention. Thanks, Jenna, so much for inviting me on this panel and for being able to speak with all these esteemed speakers, Dr. Calderwood and Dr. Morrow. And we invite your questions, so please ask.
Ryan, we had a question in the chat about whether secondhand smoke exposure can substitute at all for those 20-pack-year history criteria in lung cancer screening. Can you speak to that a little bit?
I can. So unfortunately, right now, it doesn't sub in for you meeting the criteria. It's based directly on what you have smoked yourself. They're currently looking at that though, because we do see a lot of patients that have had exposures like that or grew up in households like that or have partners or other family members within their house that have been smoking for quite some time and they have an exposure risk. The best advice that I give to patients is that if you have that within your history, be mindful of your symptoms if you have any new symptoms whatsoever. So if you have a new cold that's not going away, talk to your provider about it. You know, if you are diagnosed with something and you get a course of antibiotics and those antibiotics don't work and you're not feeling better, go back to your provider and tell them about that. But just be vigilant about your health, because unfortunately you can't get screened, but you know your body's the best, better than any of us providers will ever know them. And so if you have any things that just don't feel right, that just aren't going away, that you know, is disrupting your life, definitely talk to your primary care provider about that. I am hopeful that within the future, just like they changed the guidelines, even though it took 10 years, that they will look at this too, especially with the advent of vaping and hookah and the legalization of marijuana. There's so many other things that could contribute to this. It will take a while for us to do long-term studies and get the clinical data to back that up. I mean, if that's one of the strengths with the National Lung Screening Trial, is that we had the many years of tobacco data to back that screening up and base it solely on science, so that we're giving you scientifically based recommendations on large populations of people. But I'm hopeful that we will make advancements towards that era so that we can include other high-risk patients and not just those that have a tobacco history.
Perfect. Thank you. Well, I want to thank you all for joining us tonight. Really hope you got something out of this, learned something new, maybe even inspired to get screened or talk with your provider about screening, or maybe a family member. So with that, I hope you all have a lovely evening, and thank you all so much.